Cardiac resynchronization or CRT is for patients with mechanical dyssynchrony, especially for those with wide QRS, typically with left bundle branch block, ejection fraction of 35% or less. Its job is to restore coordinated ventricular contraction. Cardiac contractility modulation or CCM is different. It is designed for patients with narrow QRS who are still symptomatic and often have EF in the roughly 25 to 45% range. Rather than resynchronizing contraction, it enhances calcium handling and myocardial performance. Barostim or baroreflex activation therapy works through autonomic neuromodulation. It is aimed at reducing sympathetic tone and improving quality of life and exercise capacity. So each device occupies a different niche. Dyssynchrony, correction, contractility support, or autonomic rebalance. CRT works best in what is known as the QRS Goldilocks zone. Evidence has evolved. Modern guidelines have become more precise and generally require a minimum QRS duration of 130 milliseconds. This matters because CRT is not harmless if used in the wrong patient. Trials such as Lesser Earth and Echo CRT showed that applying CRT in patients with narrow QRS complex can be ineffective or detrimental. So, a short QRS is not a weaker indication. It may represent the wrong physiology. The classic strong responder is a patient with left bundle branch block with QRS greater than 150 milliseconds and often, especially in non ischemic cardiomyopathy. CRT is powerful when dyssynchrony is truly present, but precision in patient selection is essential. CCM, cardiac contractility modulation, is very different. CCM delivers high voltage, non excitatory biphasic impulses during the absolute refractory period. Because it is delivered in the myocardium, cannot be depolarized again, it does not create a new beat and does not function as a pacemaker. Instead, it alters cellular behavior. Major effects include prolongation of the plateau phase of the action potential, enhanced calcium influx, and upregulation of circa 2A. In simple terms, CCM improves intracellular calcium handling, which can strengthen contraction and support reverse remodeling. It can improve contractile performance without increasing myocardial oxygen demand in the same way traditional inotropes do. So, for the symptomatic patient with reduced EF, narrow QRS, and medication intolerance, CCM becomes an elegant physiological option. CCM can also be useful when hypotension blocks GDMT optimization. Cycle begins with device implantation in a patient who cannot tolerate medical therapy because of low blood pressure. By improving calcium handling and contractility, CCM can increase cardiac output and peripheral perfusion. As hemodynamics stabilize, systolic blood pressure rises out of the hypotensive danger zone, creating a runway. Once the circulation is more stable, clinicians can safely reintroduce and uptitrate the four pillars of medical therapy. So, CCM in the right patient can be the bridge that allows GDMT to happen. Device therapy thus functions not as a replacement for medical therapy, but as an enabler of optimized medical therapy. Barostim represents another strategy for patients with persistent symptoms, particularly when autonomic imbalance is part of the problem. The device stimulates baroreceptors in the carotid artery, which signal the central nervous system to reduce sympathetic activity and enhance parasympathetic tone. That matters because chronic heart failure is characterized by excessive sympathetic drive. Over time, that worsens vasoconstriction, arrhythmia risk, and maladaptive remodeling. By rebalancing the autonomic tone, baroreflex activation therapy may improve symptoms, exercise capacity, and longer term outcomes. There is a 34% relative reduction in the composite of death, LVAD, or transplant at over 4 years, a 44-meter improvement in 6-minute walk distance at 12 months, and a high rate of freedom from major neurological or cardiovascular procedure related adverse events. Clinically, think of barostim as a neuromodulatory option when persistent symptom burden remains, despite conventional therapy. At some point, a patient crosses into stage D or refractory heart failure. This is the destination therapy threshold. These are typically NYHA class 4 patients with severe resting symptoms, repeated hospitalizations, and evidence of a multi-system dysfunction despite optimized medical and device therapy. The key shift here is strategic. Up to this point, most interventions are trying to biologically modulate the failing ventricle. Once the native heart can no longer sustain end organ perfusion, the goal changes. We're no longer just trying to help the heart work better. We are deciding whether the patient now needs replacement of pump function with mechanical circulatory support. That is why recognizing stage D early is so important. Late referral narrows options. Timely referral opens the possibility of a temporary support, durable LVAD, transplant evaluation, or palliative discussions, depending on the overall clinical context. The Intermax profile system helps us stage how urgent heart failure has become. Profile 1 and 2 are the sickest patients. These are the crash and burn or sliding fast patients in cardiogenic shock, often requiring temporary mechanical support before they can even be considered for durable therapy. Profile 3 is the classic inotrope dependent patient. This has traditionally been the sweet spot for durable LVAD consideration, stable enough to undergo therapy but unable to come off continuous support. Profile 4 through 7 represent less unstable patients ranging from resting symptoms to advanced class 3 ambulatory heart failure. These patients may still benefit from advanced therapies, but the balance between procedural risk, survival gain, and quality of life improvement becomes more nuanced. The main point is that Intermax is not just descriptive, it helps guide timing. It tells us who needs rescue now and who needs destination therapy soon and who may still be managed with close surveillance. This slide reviews durable left ventricular assist devices. The field has evolved from old pulsatile pumps to axial flow devices and now third generation centrifugal flow systems. The current benchmark is the HeartMate 3, which uses a fully magnetically levitated rotor and artificial pulse algorithm to reduce shear stress from blood elements. That engineering matters because it translates into clinical outcomes. The Momentum 3 trial demonstrated strong survival and superiority over older axial flow devices, particularly in reducing disabling stroke and pump thrombosis. LVAD therapy is no longer a rare salvage therapy. It is a mature field with durable technology, increasingly standardized perioperative care, and meaningful long-term survival. When patients enter advanced heart failure, LVAD is one of the core options we must understand and discuss competently. An LVAD can transform survival, but it creates a new physiology and a new set of risks. Neurological complications remain important, including both ischemic and hemorrhagic stroke, often influenced by blood pressure control, anticoagulation, and infection. On the right side of the heart, postoperative RV failure is a major concern. Hemodynamic markers such as a high right atrial to wedge ratio, a low PAPI, can warn us about poor RV reserve before implant. Aortic insufficiency can emerge over time because continuous unloading reduces aortic valve opening and promotes cusp fusion. Gastrointestinal bleeding is common in part because of acquired von Willebrand factor dysfunction and shear-related vascular changes. Finally, driveline infection remains one of the most frequent adverse events. So when counseling patients, we must present LVAD as life-saving but not low maintenance. The assessment algorithm begins with a straightforward question. Does the patient have symptomatic heart failure and what is the ejection fraction? If the LVF is above 40%, it is emphasized a simpler pathway centered on SGLT2 inhibition, diuretics for congestion, and treatment of comorbidities. If the ejection fraction is below 40%, we move into the classic HFrEF management, initiate the four pillars: ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitor. After that, we assess QRS duration EKG. If the patient has LBBB with QRS greater than 130, milliseconds, we route towards CRT because dysynchrony is likely a major driver. If the QRS is narrower, then CRT is not the answer. Next step is to assess tolerance and symptom burden. So the algorithm starts broad, more quickly becomes phenotype driven. The escalation algorithm takes us beyond initial assessment. Step 4 is to determine whether the patient can tolerate GDMT, and whether symptoms persist. If the patient is intolerant or hypotensive, the pathway points towards cardiac contractility modulation as a way to bridge hemodynamics. If the patient instead has persistent symptoms despite a normal ejection fraction, the slide routes towards barostim for neuromodulation. In parallel, all of these patients should be assessed for intermax profile if advanced heart failure is suspected. Once stage D is identified, the pathway branches by urgency. Profiles 1 and 2 require temporary mechanical support, such as ECMO or Impella. Profiles 3 and 4 should prompt consideration of destination therapy with a centrifugal maglev LVAD or transplant evaluation. Profiles 5 to 7 continue GDMT with close monitoring. This is where heart failure management has become truly dynamic and team based. The closing message is that modern heart failure care is not a one lane road of progressive decline. We now have interlocking blueprint that spans a full disease continuum. SGLT2 inhibitors extend benefit across the EF spectrum. Four pillars remain the foundation of reduced EF. Devices such as CRT, CCM, and barostim help us target specific physiological barriers. And when the native heart truly fails, temporary and durable mechanical support provide a path forward. The take home principle is to match the therapy to the dominant problem. Risk in early disease, neurohormonal activation in HFrEF, hemodynamic intolerance when GDMT cannot be delivered, dysynchrony when QRS is wide, autonomic imbalance when symptoms persist, and pump failure when stage D emerges. That is the blueprint, not isolated therapies, but a coordinated strategy aimed at remodeling, survival, and restored longevity. Thank you for listening. More to follow.